Hi, my name is Flora Backus. I'm a gynecologic oncologist at The Ohio State University James Cancer Hospital in Columbus, Ohio. And it's my great honor to be here with Oncology today about key presentations in gynecologic cancers from the 2023 ASCO meeting. So there was a lot of data presented at the most recent ASCO, and I'd like to review some of the data that came out in ovarian cancer first. So one of the trials that was presented was the hyperthermic intraperitoneal chemotherapy, or HIPEC, in platinum-sensitive relapse epithelial ovarian cancer. And this was the cheaper trial, a randomized phase 3 trial. And so, like I said, this was a multi-center trial. It was a population of patients who had their first relapse of epithelial ovarian cancer. They had to have a platinum-free interval of greater than 6 months, and then they received chemotherapy. So this trial is a little bit different, that these patients first received 6 cycles of platinum-based chemotherapy for their platinum-sensitive recurrence, and then had to be eligible to have a complete cytoreductive surgery. So at this point, they were then would be assigned to surgery. And at the time of surgery, they were randomized 1-to-1 to either receive HIPEC or no HIPEC. And the other difference here with the HIPEC was that patients received 75 milligrams of cisplatin compared to the usual 100 milligrams per meter square of cisplatin, and at 41 degrees at 60 minutes rather than at 90 minutes. And then they could receive standard of care maintenance chemotherapy. Patients was stratified by center residual disease, platinum-free interval, and planned PARP inhibitor therapy afterwards or not. So here was the primary endpoint. That was overall survival in the intent to treat population. And you see the curves here that those patients who received heated intraperitoneal chemotherapy had a median overall survival of 54 months versus 45 months for those who who had surgery but no heated intraperitoneal chemotherapy. And this resulted in a 31% decrease in the risk of death compared to no HIPEC. And we see here also in the progression-free survival, that which was their secondary endpoint, that there was a decrease in the risk of progression or death, and the median progression-free survival was 11.2 versus 9.9 months. So they concluded that the addition of HIPEC was able to improve overall survival if given at the end of platinum-resistant chemotherapy.
I'm curious what you think the response to this is going to be. It kind of, from what I've been hearing, like intraperitoneal therapy sort of had gone away. Do you think this is going to change that? And the other thing is, did they report any difference based on BRCA? Because I think I'd kind of heard the idea that maybe BRCA patients respond better to intraperitoneal, but any thoughts?
Yeah, so for two things, I think this is a very interesting trial and very different than what we're used to, because typically we think about doing a debulking first. And if you're able to get to the point of no gross residual disease or an optimal debulking, then to give the chemotherapy, the HIPEC. In this case, patients received chemotherapy first and then went to surgery. So it's a little bit confusing in how, if there's still a role for it, especially also that a secondary debulking surgery has had much less uptake since the results from GOG 213, which did not show a benefit of interval, or sorry, not interval debulking, but a secondary debulking surgery in the setting of recurrent disease. And that was thought to be also probably because the use of bevacizumab was so much higher in that trial. The other trial, the DESTAR trial, did show benefit of secondary surgery in a very select population. In this setting, so to answer your question about the BRCA, um, that was looked at, and it was actually presented in one of the other trials that was presented at ASCO, where they did an update of the overall survival from the OV-HIPEC trial, which was the neoadjuvant chemotherapy setting. In the primary setting, patients received 3 cycles of chemotherapy, then HIPEC or no HIPEC during surgery, and then another 3 cycles afterwards. So in that study, actually, you're correct. It appeared that those patients in the group who were BRCA wild type, HRD positive, that there appeared to be a benefit of the greatest benefit of HIPEC. But again, those were very small subgroups. And so we don't know exactly. Here, also in this trial, there was a very low rate of maintenance treatment. And typically, when we think about a platinum sensitive recurrence, if patients haven't had a PARP inhibitor in the first line yet, then we would consider that in the second line, at least after platinum sensitive recurrence, or even doing maintenance bevacizumab. So, with less about 3 and 8% of PARP and Bev maintenance in this population here, that is so low that we really don't know how, if HIPEC is needed or if a maintenance therapy would be any better. We've never compared it in that way.
Do you know whether or not HIPEC is still being done? Every now and then I'll talk to an oncologist or gynecologic oncologist, and they say, "Oh yeah, they do it here at our place." But to what extent is it being done right now in the United States?
It varies. It varies a lot. It has been adopted more so since the data from the OV-HIPEC also. But then there's also people that are not sure what to believe. So there will be a trial that's going to open through the Gynecologic Oncology group also, which is going to study this in a very well-controlled fashion of HIPEC versus no HIPEC at interval debulking surgery. And then all those patients will get a maintenance PARP inhibitor afterwards. So it will be a very controlled situation where all patients will get maintenance. And that's, I think, where we're going to really learn, is HIPEC needed? What's the benefit? Is there truly a benefit also if you give all patients maintenance treatment? So till we have those results come out, I think some people will still be believers, and there's a camp of non-believers at this point, but it's mixed. I think probably 50-50.
It's great that they're doing the trial. Please continue.
So since we were talking a little bit about PARP inhibitor maintenance, this study presented by Harder et al. Was about the efficacy of subsequent therapies in patients with advanced ovarian cancer in the phase 3 PAOLA trial, or ENGOT OV25, according to whether disease progression occurred during or after the end of olaparib maintenance. So this was an interesting trial, and basically what they tried to answer here is is in response to the concern that if you give olaparib maintenance treatments or a PARP inhibitor maintenance treatment in general, is it possible that you could be making this next, if the patient recurs, that the next chemotherapy is not working as well, or are they less sensitive to the first subsequent therapy? So this is it's a trial that's very difficult to design. But I think they did a very nice job of doing this. So this was, just to refresh your memory, the PAOLA 1 study design included patients who had newly diagnosed stage 3 or 4 high-grade serous or endometrial ovarian cancer. They could have had upfront surgery or interval debulking surgery, and then they had to have at least 2 or more or platinum-based chemotherapy, platinum taxane-based chemotherapy, with 2 or more cycles of bevacizumab. So if they then achieved no evidence of disease or a complete or partial response, those patients were randomized to receive olaparib, 300 milligrams twice a day for 2 years with bevacizumab maintenance, or bevacizumab maintenance only. So what they then looked at was the time of first progression, whether that was during olaparib treatment or after olaparib treatment. And then they calculated the time between starting the first subsequent therapy to the second subsequent therapy, and use that basically as a surrogate for how well that chemotherapy was working for them and how long they could stay on that with a response. So, and then they compared that to the control arm of first subsequent therapy to the second subsequent therapy. So when we look at those curves, then you can see here the blue line is that group of patients that progressed while they were on olaparib. So in general, these were patients that then would have progressed within the first 2 years after starting maintenance treatment or after the completion of the primary platinum-based treatment, versus those patients in the green line that progressed after that period. So after 2 years of completing their platinum-based treatment and after completing olaparib. And you can see if you were on olaparib, and so progressed a little bit sooner, also the next subsequent line of treatment was time on treatment was shorter, with a median duration of 6.1 months compared to 11.4. And so there's two things that we can conclude from that if you progressed earlier, your next line of treatment was less effective. Or if you, that's the biggest thing probably from this trial, but because then they also compared it to the control arm where patients had not been on olaparib, and they saw that there was no difference in how the duration of response or the time on between first and second subsequent therapy, both around 11 to 12 months. So from this, we may be able to conclude that it's not the olaparib necessarily that makes the chemotherapy the next chemotherapy less effective, but rather the time, how long it takes for your cancer to come back, the time to progression, that is a more important factor.
So, in other words, this is maybe just the biology of the cancer, the fact that it recurred quicker is a more aggressive tumor?
It appears to be that way. It is hard to separate the control arm in that data set. The patients that were included there could have progressed at any time, not necessarily after 2 years. So that may be even a little bit less in favor of that arm. But for what we can tell now, yes, it doesn't appear that olaparib itself is the cause of detrimental effect on the next line of therapy.
You know, it also kind of relates to the question of cross resistance between PARP and platinum, because I assume that the chemo is going to be platinum. And I guess, you know, because the other way, you know, I don't know, at least you hear this in other cancers. I'm not sure it's necessarily true in ovarian cancer, that, you know, people who progressed on a platinum don't necessarily respond to PARP. And I guess this is sort of the reverse, using a chemo after a PARP. And like you said, it looks like olaparib is not making it more resistant. Was that your take?
Yes, yeah, I think that's a really good summary. It is. We do think that if you're platinum sensitive, you are more likely to respond to a PARP, but also the vice versa. That if you progress on a PARP inhibitor, you probably now have developed platinum resistance, and that's really what this study also is showing, that you're just less sensitive in general to platinum.
Okay, please continue.
In another study here by Graybill et al., this was the predictors of long-term progression-free survival in niraparib-treated patients, so another PARP inhibitor from the PRIMA ENGOT OV26 or GOG 3012 study. So in this study, this is for patients who had newly diagnosed disease at high risk for recurrence after response to first line. These patients in the PRIMA study were randomized 2-to-1 to niraparib versus placebo, and they were treated for 36 months or until disease progression. The primary endpoint was progression-free survival, and the key secondary endpoint was overall survival. And patients were treated with niraparib 300 milligrams daily until the weights and plates or individualized dosing schedule was adjusted based on their platelets and their baseline weight. So these were in this study, so they looked at what factors were associated with a long-term progression-free survival in the niraparib treated patients. So again, this did not include any of the placebo-treated patients. All patients in this subsequent study now only all received niraparib, and that's where they tried to look at who remains progression-free for more than 2 years versus shorter than 2 years. And you can see here from these odds ratios here in the top that BRCA status, if you had a BRCA mutation or you were homologous recombination deficient, in that case, you had a higher chance of have a progression-free survival of greater than 2 years. Even more so if you had a BRCA2 mutation, and this is kind of intuitive because if you have a BRCA mutation, PARP inhibitors appear to be working better. If you're a BRCA wild type and HRD positive, still more likely to remain progression-free. So that's not really a surprise here. Primary tumor location, if you had fallopian tube disease, was a predictor. And if you had no baseline non-target lesions or less baseline target lesions, also you were more likely to remain progression-free for 2 years. I think from this study also, the interesting part, the other things were that it was not predictive of the other factors that we think of, whether you had a primary debulking surgery or an interval surgery, or whether you had residual disease at the time of your primary surgery, and what your best response was it to chemotherapy, whether it was complete response or partial response. Those did not seem to be factors that help determine if you were more likely to be progression free for 2 years, as long as you were in the niraparib arm.
I was going to ask you, any thoughts about the tumor location? Do you think that's just a numbers thing, or has that been reported before, or what do you think is going on there?
Yeah, I think this is a big question that we don't really know what the answer is there. It's also very difficult to determine whether you are primary peritoneal disease or fallopian tube disease or ovarian cancer if you still have all those organs in place. It's really truly the pathologist trying to determine where is the biggest burden of disease, and it even is further complicated if you have neoadjuvant chemotherapy. And most of that disease may have disappeared or has significantly been reduced with just the chemotherapy where the origin was. So I find it difficult to determine there what is the location of disease. What does that have to do with it? I would agree with that. So the last thing I want to say about this study is not just these factors of prediction, but is it possible, certainly makes you wonder, is it possible that if you take niraparib as your maintenance treatment, can that negate whether you had an optimal or suboptimal debulking, whether you had an interval debulking or primary disease? I think that's a very interesting question, but again, mostly hypothesis generating, and we'll have to take a look at that in a little bit more detail and probably additional studies. More news in ovarian cancer. So Dr. Philip Harder presented this study of durvalumab with paclitaxel and carboplatin and bevacizumab, followed by maintenance durvalumab, bevacizumab, and olaparib in patients with newly diagnosed ovarian cancer who did not have a tumor BRCA or BRCA1 or 2 mutation. And so this is the phase 3 DUO-O ENGOT OV46 GOG 3025 or OVAR 23 study. And so here's the trial design. Patients first had a run-in phase of chemotherapy for 1 cycle. And so this trial included, again, newly diagnosed patients who had stage 3 or stage 4 high-grade epithelial ovarian cancer, no prior systemic therapy, and they had to be PARP inhibitor naive. They had to have either primary debulking or planned interval debulking, and they could not be tumor BRCA mutated, because we had the data already that if you had a tumor BRCA mutation or germline BRCA mutation, those patients should be receiving a PARP inhibitor given the great beneficial effects here. So if you did not have a tumor BRCA mutation, then patients were randomized between arm 1, which was chemotherapy with bevacizumab, arm 2, chemotherapy with bevacizumab and durvalumab, or arm 3, which added was also bevacizumab with durvalumab, but then after the completion of treatment, the patients then had olaparib added, whereas the arm 1 and 2 had olaparib placebo tablets. The primary endpoint was progression-free survival in arm 3 versus arm 1, and that's what's presented here. And again, this was in the non-tumor BRCA mutated HRD positive population and the intent to treat population. So here's the primary outcome. When we look at this, about 25 months of follow-up here. The median progression-free survival is the longest in arm 3, which was the combination of chemotherapy with bevacizumab, durvalumab, and olaparib, compared to the chemotherapy in the light blue line, chemotherapy with bevacizumab alone. And we can see here that in that comparison, there was a 37% decrease in the risk of progression or death between those two arms. Interesting here is that you can also see that there is no olaparib only arm. So this, what we think also here is, yes, you have the bevacizumab standard arm. Is it the olaparib that is added here, kind of like the PALA regimen, or is it also the durvalumab contributing here that may improve the outcomes in this situation? So if we then look at the differences here, the progression-free survival in the HRD positive population, so not the intent to treat, but the HRD positive population, we see here a significant difference also. The median progression-free survival, 23 months with bevacizumab maintenance alone versus 37 months when you have bevacizumab, durvalumab, and olaparib combined. And here we see a 51% decrease in the risk of cancer progression or death. As demonstrated here, the 24 mark, we see 70% of patients progression-free versus 46% if there was bevacizumab only.
Kind of curious what your take is on this study in terms of clinical applicability. I hear docs in practice, sometimes they run out of options and they try, I don't know how they get it paid for, but, they get a checkpoint inhibitor and a PARP inhibitor. Do you think that's a reasonable thing to do? Does this study give you any reason to think durvalumab has a role, or IO has a role in ovarian cancer?
Yeah. So in ovarian cancer, we haven't been very successful, absolutely, with adding IO in ovarian cancer. We had the results of the Imagine study also, which was also immunotherapy and antivascular agent. With bevacizumab also. So that was with atezolizumab. So those studies have all been negative, and other studies where we've added immunotherapy have been negative. So here, I think the hardest part here is, again, that there is no arm where there was bevacizumab and olaparib only without the durvalumab. So it's really hard to tease out if durvalumab is truly contributing anything to these outcomes, or if it's purely the PARP inhibitor in these populations.
Please continue.
The Mirasol is a phase 3 trial, GG 3045 and got OV55 study. This is mirvetuximab soravtansine versus investigator choice of chemotherapy in platinum-resistant advanced high-grade epithelial ovarian primary peritoneal or fallopian tube cancers who had high folate receptor alpha expression. And so this has been a long time coming, really important study. Certainly very excited to see the results that Dr. Moore presented. So here was the study design. These were patients who were platinum resistant, so platinum-free interval less than 6 months. They had to have folate receptor alpha detected by immunohistochemistry, and they had to have high positivity in greater than 70% of the viable tumor cells. Again, high-grade serous histology, first-line platinum refractory disease was excluded, and they had to have 1 to 3 prior lines of treatment. The nice part was that prior bevacizumab and prior PARP inhibitors were both allowed, and patients with a BRCA mutation were also allowed. Patients were randomized then to mirvetuximab, 6 milligram per kilogram, adjusted ideal body weight every 3 weeks, or investigator choice chemotherapy. And the investigator had to choose between weekly paclitaxel, pegylated liposomal doxorubicin, or topotecan. And then they were stratified based on the choice of investigator chemotherapy and a number of prior lines of chemotherapy. Primary endpoint was the progression-free survival by investigator analysis. And then the secondary endpoints were objective response rate by investigator assessment, overall survival, and then the patient-reported outcomes. And here's those outcomes that we see the curve. So in yellow, we see the progression-free survival for the patients who received mirvetuximab, versus in blue, who received the investigator choice chemotherapy. And you can see in the table here also that the median progression-free survival was 5.6 months versus approximately almost 4 months with the standard chemotherapy, which resulted in a hazard ratio of 0.65. So 35% decreased risk of progression or death if you received mirvetuximab versus chemotherapy. And I think here what the other interesting part is that we see where the red arrow is pointed at, that how fast these patients progressed when they received investigator choice chemotherapy. You see that blue curve is dropping really quickly. So the red arrow where the first imaging assessment is, a lot of those patients are already dropping off, whereas the mirvetuximab seems to have a continued benefit here. And then if we go to the overall survival, again, very, very interesting. We see now for the very first time in platinum-resistant ovarian cancer that there's an overall survival benefit here, with a 33% decrease in the risk of death from ovarian cancer in the population if you were receiving mirvetuximab versus investigator choice chemotherapy. So we see that the median overall survival is 16.5 months versus 12.75 months with chemotherapy. And if we look at these curves, we don't see that all that often, that the curves are narrower in the beginning and they continue to diverge as time goes on. So this is a lasting effect and almost looks like a continued beneficial effect as time goes on. So slower response here, but great outcomes and a very great option for our patients. And I don't think I showed it here, but the objective response rate also were more than doubled in this population, 16% versus 42%. So really seeing a big benefit all the way around. Here, as we look at the safety data also, these are treatment emergent adverse events. We can see here, of course, it's a little bit different for every type of investigator choice chemotherapy, depending what the side effects are. But we can see if we look at the hematologic side effects that mirvetuximab has a low rate of neutropenia, anemia, thrombocytopenia, and a very low rate of grade 3 or greater hematologic side effects. Neuropathy also is a little bit lower than what we see with weekly paclitaxel. Barely any alopecia, 1% only. The other side effects, such as diarrhea, nausea, fairly similar between the regimens. And of course, and one of the most concerning thing that we know that there can be some bystander effects in from the mirvetuximab on the eye, mainly on the corneal layer. So we do see some blurred vision, keratopathy, and dry eye in these populations, things that we are not used to seeing with investigator choice chemotherapy. But overall, these are low grades, very low percents that are grade 3 or greater, and low percentage of patients that would need to discontinue their treatment for this reason. And really important to remember that most of this, since the corneal layer does turn over, by holding your dose or even decreasing the dose, we can certainly see quick resolution of these symptoms, and extremely rare for these symptoms to be something permanent. The Gloriosa trial is a follow-up trial to this study, really, now in a different setting, not the platinum recurrence as in the platinum resistant setting, but this is in the platinum sensitive ovarian cancer population, for patients who completed chemotherapy. So here's the design. So this is patients who are first going to receive a platinum-based chemotherapy with bevacizumab. And then if they have a complete or partial response or stable disease, then there's a randomization. And they anticipate approximately 418 patients to enroll on the study. And they'll be randomized to either receive the bevacizumab maintenance treatment, as they were receiving with a platinum-based chemotherapy, or with the addition of mirvetuximab given every 3 weeks. So this is a trial in progress and anticipated to continue to enroll here in the maintenance phase. So another option, especially for the population, as we are seeing more PARP use up front, some other maintenance treatment options in the recurrent setting. And there's some more maintenance treatments that we're going to be seeing here also. So this is the Up Next study. This is a different antibody drug conjugate called UpRi, which targets NaPi2b. And the design is somewhat similar to the Gloriosa study that we just looked at. Again, patients with platinum-sensitive recurrent disease, 4 to 8 cycles of platinum-based chemotherapy in this, and then they have to have a response to treatments or at least no progression. They have to be NaPi2b positive based on an archival or fresh tumor biopsy. But patients who cannot have received bevacizumab along with their treatment for recurrence with the platinum-based treatment. So that's a big difference with the Gloriosa study. So here's about 350 patients that are planned to be randomized. This will be UpRi given every 4 weeks versus placebo every 4 weeks. And again, this is maintenance treatment with the primary endpoint of progression-free survival. Then Upgrade A uses the same drug that is here used in also the platinum sensitive setting, but now not in maintenance, but as a treatment. And in this trial, so this is also a trial in progress, the patients with platinum sensitive disease are enrolled. They can have 1 to 3 prior lines of treatments. Here we see UpRi with carboplatin, so it's a single arm study. It's currently in dose expansion. This is carboplatin with UpRi. given every 4 weeks again. And then after 6 cycles, this would go into UpRi maintenance. Primary endpoints, a little bit different than what we're used to seeing here. This is the feasibility of UpRi, and that is defined as 60% of the patients who can receive at least 4 cycles of the combination treatment without needing a discontinuation for anything else than progressive disease. So we'll see what this trial shows. And then this study was also presented by Dr. Richardson, where we're looking at these biomarkers. So all these antibody-drug conjugates have their own biomarker, and here they looked at some of the tumor samples from 84 patients in the UpRi phase 1 expansion study. They looked at archival and fresh tissue samples, and then looked at some of the patients also who had both. And they looked both at the patients who were positive for NaPi2b and for folate receptor alpha, and did this by RNA analysis, RNA expression by nanostring, and then also looked at it with immunohistochemistry. And you can see here that there was not a ton of correlation between the two, only 21% that were both folate receptor alpha positive and NaPi2b positive. So these are things that have to be analyzed separately. And this is really just an exploratory analysis to see how much overlap there is. Here they also look at the NaPi2b by immunohistochemistry versus doing this by RNA expression by nanostring. They saw that 45% of the patients were positive for both. 24% of the samples were negative for both. And then there was almost a 70% agreement between the RNA and IHC that you can see here depicted in this graph as well. That was a lot of the data for ovarian cancer already. Let's go over to endometrial cancer. So the Ruby trial has been previously presented and was now presented by Dr. Powell also. And this was interesting that they looked at this time at the outcomes by blinded independent central review. So not by investigator initiated study, but they compared the outcomes between investigator initiated and blinded independent review. So you're probably all familiar with this. This is a trial for patients with recurrent, advanced or recurrent endometrial cancer, stage 3 or 4 disease, with a low rate for cure. They had to have measurable disease. Carcinosarcoma, clear cell serous were allowed also. And they had to be naive for systemic chemotherapy or had to have chemotherapy more than 6 months after the completion of treatment. They were randomized to chemotherapy with or without durvalumab, and then durvalumab maintenance versus placebo maintenance. And if we look at the two curves, very reassuring that what we do as investigators when we do the investigator assessment for progression is not much difference compared to the blinded independent central review. Hazard ratios almost exactly identical, still approximately 70% risk of decreased risk of progression or death in the mismatch repair deficient population. Similar median progression-free survival for the placebo group, maybe slightly better by blinded independent central review. But again, very reassuring. Similarly, in the progression-free survival in the overall population, these curves look very similar. The hazard ratios are similar, and so are the median progression-free survival in months compared to the originals. So great outcomes with the addition of dostarlimab, whether you look at it as an investigator or send it for central review. They followed this up with the patient-reported outcomes for the first time presented here by Dr. Mirza, We just looked at the trial design. In this study, they looked at several questionnaires that were used to collect the patient's health-related quality of life data, and they were completed at multiple time points: cycle 1, cycle 7, and cycle 13. And so these were global health, functional skills, and regarding symptoms. And we're going to take a look at where we see these curves. So this is in the mismatch repair deficient population. So what we can see here, and an improvement is when the score goes up. The blue columns are the patients that received dostarlimab versus red was placebo. So improvements in global health, in role functioning, emotional functioning, and we see here the difference also that there was an improvement or relative improvement if you received dostarlimab also in cognitive and social functioning compared to placebo alone. And if we look in the overall population, here we see that the outcomes are not significantly different. If anything, there's no detriment of adding dostarlimab to any of the patient-reported outcomes. Also, that this is at cycle 13. So this was at the first year of the end of maintenance treatment. We see great improvement here in the overall on almost all domains in the mismatch repair deficient population. And much more so if patients were on dostarlimab versus placebo. And again, no detriment of adding immunotherapy to chemotherapy compared to the placebo alone. And then this is an ongoing study. Is it needed that patients are also still need to get the chemotherapy? And this hopefully will give us somewhat of an answer. This is the Dominica study, a trial in progress that is comparing chemotherapy alone, so carboplatin paclitaxel versus dostarlimab single agent immunotherapy in a similar population as we just saw in the Ruby from the Ruby study. So this is the trial design. This is just in mismatch repair deficient population, again, metastatic or advanced patients with stage 3 or 4 disease. They are randomized to 130 patients in each arm to dostarlimab by itself or chemotherapy by itself. Of course, the biggest question is going to be, is this currently, after the Ruby trial resulted, is this still the correct comparison arm? This population is going to continue to enroll. About 50 patients have so far been enrolled out of the 260 patients needed, and this is mostly done in Europe. Then cervical cancer. This was the update presented by Dr. Monk of the pembrolizumab with chemotherapy versus placebo with chemotherapy for patients with persistent, recurrent, or metastatic cervical cancer. And this is the final overall survival results of Keynote 826. So as a reminder, this was a study of persistent, recurrent, or metastatic cervical cancer that was not amenable to curative treatment. Patients had to be chemotherapy naive, but chemotherapy with radiation was allowed. And then they were randomized to standard chemotherapy of either paclitaxel with cisplatin or carboplatin, with pembrolizumab or without. And then patients could receive bevacizumab also in addition to their chemotherapy. There was dual primary outcomes of overall survival and progression-free survival by investigator. And so here is that final overall survival analysis, and this is from the PD-L1 positive combined positivity score of greater than 1 population. We see here at this point that the overall survival continues to be beneficial. The curves are still separating and almost look like they continue to separate more and become more divergent here. The median progression-free survival, if pembrolizumab was added to chemotherapy, was 28.6 months versus 16 months with chemotherapy with or without bevacizumab. So almost a year in addition here if pembrolizumab was added in this population. And great results here also that it wasn't just in the PD-L1 positive population, but if you look into all comer population here also, we see that has a ratio of 0.63, so 37% decreased risk of deaths from cervical cancer, again, was a great benefit, 26 months versus 16 months in overall survival. And we see a benefit here for the progression-free survival also. And this curve is here that is showing also that it's not just that it is a benefit across all subsets, including with or without bevacizumab.
It looks like less than one PD-1 level, like the hazard rate looks, I think I'm seeing it right, is about one.
Yeah, that is correct. So yes, it is absolutely the pembrolizumab in combination with chemotherapy is currently approved for the PD-L1 positive population. So yes, well, it's correct that while the outcomes in the overall population, which included the PD-L1 positive and negative, we see the benefit, but it really seems to be driven by those patients that are PD-L1 positive. Greater than 1 and even greater than 10. Absolutely. We have one more study for cervical cancer that was the SHAPE trial, and this compared radical hysterectomy. It's not a treatment trial, but still a very important trial. Radical hysterectomy with pelvic lymph node dissection versus a simple hysterectomy with pelvic lymph node dissection in low risk early stage cervical cancer. So as we're doing more neoadjuvant chemotherapy, get better drugs, we're also investigating whether these radical surgeries are still needed for all patients with cervical cancer. So this study, you have to remember that this enrolled a very particular population of patients with stage 1A, 2, and 1B1 cervical cancer. They had to have less than 10 millimeters of stromal invasion on a LEAP or cone, or less than 50% of stromal invasion on MRI, and the maximum dimension of the tumor was 2 centimeters. So if they met all these criteria, they could be randomized to the control arm, which was a radical hysterectomy. With lymph node dissection, that could be full lymph nodes or sentinel lymph nodes versus a simple hysterectomy. And the primary outcome was pelvic recurrence at 3 years. So here we see the outcomes for the pelvic recurrence rate. The recurrence rate at 3 years was overall very low, 2.5 versus 2.17%. The curves are very similar, and there was no significant difference. And the investigators conclude then that there's non-inferiority of simple hysterectomy to radical hysterectomy. The pelvic recurrences overall, so not just 3 years, were 3%. So that was low. And extrapelvic recurrences also, we see only 1.3% had extrapelvic recurrences. Slightly higher numerically here in the simple hysterectomy group. And you can see in the table that these are somewhat split out, but very reassuring. And with this, the investigators conclude that for this particular subset of patients that have a small tumor with no deep invasion, that a simple hysterectomy would be with lymph nodes is an appropriate treatment, and radical hysterectomy may not be necessary. And maybe one of the most exciting studies that was presented at ASCO across all tumor types, and this is the efficacy and safety of trastuzumab deruxtecan, or TDXD, in patients with HER2-expressing solid tumors, the Destiny Pan tumor, and this is interim results. So this study enrolled advanced solid tumors that were not eligible for curative therapy. Second-line patients had to have HER2 evidence of HER2 expression with IHC 3+ or 2+. Either by a local or a central test, gastric cancer guidelines, and then prior HER2 targeting therapy was allowed. They had several cohorts that you can see listed here, and patients received TDXD 5.4 milligrams per kilogram every 3 weeks. And the primary endpoint was confirmed objective response rate. So if we look here across, and in the green box here, you can the GYN cohorts are highlighted. We see fantastic response rates here, 50% objective response rate in cervical cancer, 57.5% in endometrial cancer, and then 45% in ovarian cancer also. That's slightly better than all the patients, but still, if you look at all these patients in all the different disease types, also 37.1% objective response rate in this difficult to treat population, with a fair number of complete responses, also stable disease, and thus the disease control rate at 12 weeks is very high, somewhere between almost 70% and 80%. With a long median duration also. So very, very exciting results here. You can see from these graphs that the red dots are the patients who had IHC score of 3 plus, but you see that not all these patients have it. A lot of patients with deep responses, but also here a fair bit that don't quite make it to the partial response mark at 30%, but still had a decrease in tumor volume and tumor size. And then here it is split out between patients who had, for all comers, whether they were IHC 2 plus or 3 plus. You can see here the highest response rate, certainly in the groups that had 3 plus disease, but excellent responses also among those who had immunohistochemistry score of 2 plus, with long response rates. Again, 11 point, almost 12 months for all patients, 3 plus, about double the duration of 2 plus, but really great responses across all.
So one issue about this, and I'm curious, I don't know, in breast cancer, not only do they do IHC, but they do FISH. And I guess one of the things, the last thing you just showed there with the responses with IHC 2 plus, which would not normally be considered positive if the FISH ratio was less than 2. So do you know whether or not they actually did FISH on these patients?
It was not a requirement for eligibility. I can't say that for sure. I think the other interesting part of this study was that then they did do a central review of all specimens. So they had their the ones from local results for eligibility, but when they did their central review, they also saw that 9.4% were 1 plus and 11.2 were actually HER2 negative. And those patients were all treated and included with the study. So they haven't given out the results yet for what are the specific objective responses in those patients that were actually turned out to be, by central review at least, HER2 1 plus or HER2 negative. But I think it will be very interesting to see those results, certainly in light of the breast cancer data that also show that HER2 low also has great responses.